this computer. Okay. Hi, everyone. Welcome to our talk. We're so excited to have you here. I'm about to start sharing my PowerPoint screen, and we're going to go ahead and introduce ourselves throughout the PowerPoint. And we really hope that you enjoy it and jot down questions along the way so that you can have all the questions ready for our live Q&A. So let me work magic right now, real quick. Here we go. I think it's working. So I'll go ahead and introduce myself first. My name is Emily Bailey, and I'm a clinical psychologist that practices out of Atlanta and the founder of Atlanta OCD and Anxiety Treatment. Also PsyPact certified. So yeah, that's pretty much about me. I also teach on the side, and I'm just so excited to be here.
My name's Christen. I am a co-founder of the Houston Center for Valued Living, where I'm the clinical director and a behavioral therapist. And so excited to be with you guys today and excited to get into questions.
And I am Annabella Hagen, LCSW. I am the clinical director and founder of Mindset Family Therapy here in Provo, Utah. And I'm passionate about this topic, and let's have some fun.
Yeah, I'm ready for this. And I'm going to go ahead and apologize to everyone, but allergies are getting the best of me today. So you're going to probably hear me sniffling, and we're just going to embrace it. And it's going to be great. So some learning objectives before we really get into the nitty-gritty of what is OCD and what is ERP. We really want to aim here to provide mental health professionals with insights, with effective strategies for treating religious scrupulosity using exposure and response prevention. And we really want to offer some guidance too in, implementing ERP successfully, understanding those mental rituals such as repetitive prayer, understanding avoidance, understanding how reassurance seeking plays a role, and just providing some practical advice about how to integrate faith leaders into our cases. I really hope you enjoy this, and we're going to hit all of these points and hopefully have all the questions to answer for you after. So for those of you who don't know what OCD is obsessive compulsive disorder. It's often defined, in the media, mainstream media, as this like quirk. And that's such a misconception. OCD is a debilitating disorder that's really characterized by two different things: these unwanted obsessions that provoke anxiety and distress in an individual, as well as compulsions that are engaged in repeatedly to try and alleviate that anxiety and distress that the obsession causes. And the obsessions that seem to stick, the obsessions that seem to come up most often for individuals are in the domain of the individual's life that they feel is really significant for them. So OCD essentially hijacks your values and morphs them into something that's more unrealistic or more rigid. So in general, I just want to say everyone has intrusive thoughts. Everyone has these obsessions. However, individuals diagnosed with OCD tend to place more emphasis on the meaning behind the thought and get caught up in it a little bit more. They become concerned that the thoughts may mean something about them as a person, or that they are overly responsible for ensuring that something doesn't occur related to the thought. And although there are many, many, many subtypes of OCD, today we're going to be focusing on scrupulosity OCD. And it can be just helpful to keep in mind that this can be challenging for both the individual who is diagnosed with this, but also the provider to distinguish between OCD-driven intrusions as well as these healthy faith practices. So already here, I just want to insert a component of remain self-compassionate, even when you're the one that is treating. Because it can be difficult. The obsessions can have nuggets of truth or be based on standard religious practices, but just be slightly skewed. And when time really starts to, when these experiencing these obsessions and these compulsions start to interfere with time and interfere functioning in daily life, that's when it's disordered, and that's when we need to intervene. So let's talk scrupulosity. So scrupulosity subtype is divided into religious scrupulosity and then moral scrupulosity. And moral scrupulosity really revolves around the fact that, They have a fear that they're inconsistent with some sort of moral compass that they have, or if they're a good person, if they're a bad person. This is often cultural as well. It's influenced by societal standards. But religious scrupulosity is the main portion that we're going to be focusing on today. And this is when an individual experiences intrusive obsessions that latch onto faith, their beliefs, their spirituality, or their religious traditions. And, you know, of course, this is really important to the individual. So they feel stuck and they feel driven to do whatever they can to make those thoughts go away and feel less anxious and uncertain. One of the primary concerns with religious scrupulosity is this uncertainty about whether they act in a way that's inconsistent with whatever religious doctrine they practice. So individuals with religious scrupulosity may interpret their religion or their faith practices in a really extreme way or in a really rigid way. And again, I want to remind you that these obsessions are not reflective of values-driven faith. This is not something they view as in line with who they see themselves as. It's ego-dystonic. So it distorts the customary faith practices beyond a normal level. And these compulsions are often, unfortunately, misinterpreted as really devout faith practice. But in reality, they're driven by fear versus that normative faith practice that's driven by connection and hope and meaning. So here are some examples. I'm not going to go over all of them. I know you can see them on the screen, but depending on your faith practice, there may be different obsessions that come up. This is not an exhaustive list. Let me just say that. Hinduism could be, what if I performed puja incorrectly? With Buddhism, it could be, what if I have poor karma? Judaism, what if I'm not following dietary restrictions exactly right? Christianity, did I have a blasphemous thought against God or Jesus? Islam, what if I missed a spot when doing wudu? If I don't repeat it, my prayer won't count, right? So these are examples across faiths. This doesn't just target one faith. And some compulsions here could be overt or more covert and private. So some overt could be excessive praying, avoidance of places of worship, cleaning or re-cleaning yourself, seeking reassurance from faith leaders or family accommodations, right? Or there could be more ruminating, rationalizing, trying to figure it out, questioning one's own character. And sometimes prayer can be covert too, right? You can be praying inside your head, right? Another thing to think about is just family accommodation as a role and reassurance seeking as a pretty big role in maintaining this behavior.
All right. Yay, I get to hop in. I think like you, Emily, we're having a lovely allergy day today. So y'all just bear with me for just a minute. So just to kind of nutshell ERP treatment, we're going to outline more of the details as we go through and walk through an interesting case, and as we learn more about what exposure and response prevention looks like when used in conjunction with acceptance and commitment therapy. When we meet clients, you know, as always, we want to meet them where they are. And for some OCD clients, that can be very different. I mean, it is going to vary a lot from person to person. Making sure that we're utilizing the correct assessments as we get to know the client and the OCD. Some assessments, just general ones, the Y box, always fantastic. And then we have the PIAS, where we look at where some of those obsessions, particularly with scrupulosity, are focused. We want to know where the client is possibly seeking reassurance from. Are they seeking reassurance within their family, friends? Are they reaching out to clergy? Are they engaging in a lot of confessions? So educating the client and having them learn more about OCD in general, tracking avoidances, triggers, and this is important later when we're going to talk about mental rituals and how helping the client get to know what their OCD kind of sounds like and feels like for them can really help differentiate between what an obsession is for them and that mental ritual, because they can be so automatic. So building a hierarchy with the client, doing exposures in session with the client, having client repeat them, going through relapse prevention with clients, and just really walking them with them all the way through the treatment process. And we've included a little OCD cycle over there on the right. So you can see that we start with triggers, helping them learn what triggers are, obsessions, rituals, and all the way around as they continue through the cycle. I think Emily is the next one, the fantastic case example. Yes.
Alexis, also known as Lex, a pro. So Lex is somebody that we thought would be really helpful to walk through what treatment may look like, particularly in this case. The idea here is that we've probably already assessed her, right? We've probably already done the Y box, had an understanding, and explained some of the OCD cycle with her. She's a 28-year-old female who is presenting with concerns of scrupulosity OCD. One of the questions we would be asking is, what religion does she identify most with? And for her particularly, she said Christianity, non-denominational. And by working through some of her obsessions and trying to understand them at a deeper level, we recognized her core fear as she was fearful of going to hell. Some of the obsessions she noted was, did I commit a sin? Did I pray right? Is God angry with me? And as a result of experiencing those really distressing thoughts, she engaged in compulsion. This included confessing potential sins, seeking reassurance from family, praying repeatedly until it felt just right for her, avoiding the church, as well as ruminating.
Okay, so Emily already mentioned that OCD is ego dystonic. That means the thoughts and the doubts don't match the type of person they are or want to become. In this case with Lex, she is trying to have pure thoughts because her religion has taught her that she should not have impure thoughts. So there's a conflict here. So the religion is ego symptomic and OCD is ego dystonic. So within her, she is trying to have the pure thoughts, and then she may experience shame because she's not able to. So we need to be aware that when you're treating scrupulosity, it is difficult for them to recognize that they have to learn to allow those thoughts and doubts that are considered impure. And we're going to be talking about that in a few minutes.
Yeah, and related to that, just kind of going through, and I don't know why this is cutting off right now, the OCD cycle as it applies to Lex. Don't worry, guys, I will read it for you since you probably can't see all of it. But let's say her trigger is prayer. And her obsession is, what if I didn't recite my prayer correctly? She may have a belief about this obsession. And this belief about the obsession actually makes that obsession feel more important and actually stronger. So an example of a belief about an obsession is maybe intolerance of uncertainty. So maybe she feels like she must feel 100% certain that she did the prayer correctly, and any hint of doubt feels unacceptable for her in that moment. Because of that belief and how it fuels the obsession or the obsessional thought that she has, she engages in a compulsion, which is to repeat the prayer over and over until she feels like it's just right. When she does this, she experiences a temporary anxiety reduction. But when that trigger comes up again, this cycle begins all over again. So what we want to do when we're thinking about ERP is we're wanting to target the compulsion. We can't control the thoughts that come into our head, but we can target how we react and engage with the thoughts. So a lot of ERP is focusing on eliminating this compulsion.
Okay, so a lot of people worry, a lot of scrupulous people worry about how ERP may take away their faith or will make them less religious. And I just wanted to remind you that ERP, the purpose is for the client to change their relationship with their internal experiences, which means thoughts, feelings, sensations, doubts, etc., and with their external experiences. For example, the person may not want to watch a TV show because it triggers them to have impure thoughts. In this case, Lex may be reluctant to watch a show like that because she will believe that, no, if I watch this show, I'm going to be sinning. That's OCD talking. So when we do the ERP, we are going to explore values. In this case, this lighthouse represents her values, her guide. The values will be the overarching piece in ERP when we do acceptance commitment therapy, ERP, where she will discover, as she explores her values, maybe she will discover that her value is connecting with God. So she wants to connect with God, and she will learn to do different psychological flexibility skills to be able to do that. And we are going to be talking about that on the next slide.
I have to say, I love this photo. I love the lighthouse as kind of a guide for values. And like, ERP doesn't make us less religious, but sometimes the treatment feels like that, right? And I think you made a great point of how values is what we want to drive the treatment and the exposures we select. And at times that will feel a little sticky, right? We may ask you to pray less, right? Or engage in a behavior less that you view as religious, but that's actually just really OCD skewed, right? And so ERP, we will never be asking you to do things that aren't in line with your religious beliefs, right? We want you to do things that you value, but we don't want it to be fear-based. We really want it driven by that connection. So I just love this slide. I just wanted to say.
Okay, so I have a few words here. We'd like to invite you to first look at the hexaflex, the graphic that is on the left. These are the 6 principles or processes of ACT. And in short, it will be for Lex to learn to become open to the internal and external experiences, which means to be willing to have the thoughts. And one of the skills that she will learn is to acknowledge the thought, to not be afraid of the thought, to not fight the thought, but to acknowledge it. Most of our clients are wanting to get rid of the thoughts, but they learn to just notice the thought and acknowledge it. That would be the diffusion part. And then the acceptance part would be where the client also does not like to feel uncertain, who likes to feel uncertain, right? Or the unpleasant feeling of shame or guilt. And so they learn several psychological flexibility skills to learn to be open and accepting of them, because at the end of the day, as Emily said, we cannot control our thoughts or feelings, but we can control what we do with them. We can learn to respond to them, and the client learns to, for example, make room for shame. And they may say, shame is here, I don't like it, and I can make room for it. And then they do the skill of, example would be breathing in, and as they breathe in, they say hello, and as they breathe out, they say, old friend, shame is here. I can make room for you right now in this moment. So the present awareness is important, and they learn skills to catch themselves doing something different, which will be the compulsion. We want to be able to have the client respond differently. And instead of doing rumination, instead of doing other compulsions, they will learn to do psychological flexibility skills, which is allowing the thoughts and feelings to come and go as they normally do. In order to do the ERP with ACT, we usually address the life domains, the areas in their lives that they have neglected. In this example, we will say maybe spirituality has been neglected because Lex is not going to church, maybe is not reading her scriptures, is not praying because she feels unworthy or she feels like God is angry at her. So she has been avoiding that. So we will explore the life domains that she would like to revisit and create goals there. And the goals will be related to the values. In this case, maybe it's the value of loving, maybe it's the value of connecting, maybe it's the value of serving. She gets to choose the values, and as she goes about life, she chooses to live a value-focused life, a value-centered life where things present themselves. She wants to go to church, and she will remember her why. Why am I doing this hard thing? I'm doing this because I want to connect with God. So in short, ACT, we can say the client learns to accept their thoughts and feelings and be present. They see, she chooses a value direction and takes action. And let's go to the next slide so we can talk about the willingness scale. With ACT, what we want to do is for the client to not necessarily measure when her anxiety goes down, but we want to measure her willingness to experience these things without fighting, because we know that the fighting, the resisting is the problem, is not the thoughts, is the fighting with the thoughts that makes OCD get magnified. So we have the willingness scale that is taken from Christen Neff's book, and we have the reference there later on. But what the client is doing is resisting, is just, I don't want it, and I want to fight it, or avoiding it. I always say to my clients, and in this case, I will tell Lex, let's just be curious. Let's just explore what happens when you are not fighting the thought. What would happen if you don't fight the thought and you actually acknowledge it? What would happen if you breathe in the unpleasant feeling for as long as you want to? So what we want to do is for them to do the exposure, meaning the thing that they want to do, example, going to church, but they choose how long they're going to do it, and they choose to explore first. Because the truth is, our clients usually are all or nothing thinkers. They set themselves for failure because they say, okay, I'm going to go and I'm just going to do this and I'm just going to white knuckle. And I said, okay, you're doing that already. This is not what we want to do. We want to develop awareness when you are start white knuckling it. And here we can see that we have tolerating in this case. But in this case, we can say, okay, I hate it, but I can endure a little longer. That's the attitude that we want our clients to have. Not to say, okay, when is this over? When is this over? But it's like, okay, I don't like it. I don't ever have to like it. I always tell clients, we're not trying to change the way you see your feelings, meaning I have to like uncertainty. I have to like shame. No, nobody likes this. What we're trying to do is learn how to allow it to be in this present moment and let it be, because at the end of the day, thoughts and feelings come and go. They're always coming and going, but when we grab it and say, why do I have it? I should not have it. That's when it gets bigger. So we're trying to help the client learn to explore, and eventually, and I said, this is a process. Please don't be in a hurry. The allowing, the befriending it is going to be later on. Allowing will be where Lex says, I'm noticing the sensation and I can create space for it right now. And befriending, Lex will say, what value may be on the other side of this struggle? So I love this willingness scale. And in my opinion, the main treatment for clients is for them to learn this. Because if they don't learn to be willing and start with exploring, they will not be able to do anything, and they will continue to resist and have not a value-centered life.
Annabella,
Anybody wants to add anything to that?
I love
Christen,
that you brought up the that they never have to like it, right? Like that's not the point of the treatment process. you don't have to like what's showing up, right? It's just learning to change our relationship. Am I willing to let it be here? And yeah, the science experiments are awesome. I love it. Amazing.
Yes, thank you. So the next slide, we talk about these are exposures that we all do, whether it's with ACT or inhibitory learning or ICB. Well, ICBT is a little bit different, but anyway, we're talking about ACT here. And with bodily sensations, we know they're interoceptive exposures, but the difference here with ACT is I invite the client to, let's say the client is going to be running in place to create the fast heart palpitations. And in this case, I invite the client to maybe trigger themselves with a thought that is, I tell them, I said, just go ahead and ruminate for a few seconds to get you going. And then for them to realize, okay, the fast heart palpitations are natural. But when I add the thought, that's when I am afraid, but it's not necessarily the bodily sensation. We talk about how, who doesn't like going on a roller coaster? Well, what happened, Emily? You've been to a roller coaster recently,
I like
right?
all roller coasters. You put me on any roller coaster, I'm game. Let's do it.
And what happens? What happens when you're in a roller coaster?
So I initially regret once I'm like strapped in, I'm like, oh no, this was probably not the best decision I've ever made. And then I get really anxious, but right when it takes off, I'm like, this was worth it. Like you get almost like a rush of adrenaline, but almost like your anxiety turns to excitement.
Exactly. So I always tell the client, there is no difference between you being in a roller coaster that you enjoy or sitting in your living room with the thoughts. The difference here really is not the fast heart palpitations. The difference is the thoughts. And you are linking the thoughts to these sensations. And what we want for them to do is recognize, oh, there's that thought. I can acknowledge that thought. There is the sensation. I can create space for this sensation. And why am I doing this hard thing? Oh, my value, connecting with God. Then the imaginal exposures here is very fitting because Lex is fearful of going to hell. Well, we cannot take Lex to hell right now, right? So we want to invite her to do an imaginal exposure. We can do it with scripts, or we can just do it simply with a mindful activity where she literally is there. Maybe she's being in front of God and God is saying, okay, Lex, you're going to hell. And of course, I ask them to do that so that they can create that anxiety and guilt or shame, whatever experience is there. And then we practice the psychological flexibility skills to be open, to be aware, and to be actively engaged, in this case, in the exposure and recognize I'm learning to be flexible with my internal experiences. And then the in vivo exposures, let's go to the next slide.
Sorry.
Okay, this is basically a summary of what we would like to invite the client to do. Adopt a willingness stance, meaning as you get up and you start living your life, you want to say, bring it on. I'm not afraid of your thoughts. I'm not afraid of your feelings of OCD, basically, because you know what? I can learn to be flexible with these things. And so when a thought shows up, I'm going to say, yeah, I'm noticing that thought, OCD. And I usually ask my clients to name their mind. So we have names like Gary, Carlotta, Yoda, they usually use names like that because, again, is the fusion part is creating space between me and my thoughts. So when Yoda is around, yeah, Yoda thinks that it knows it all. And I'm going to say, Lex can say, yeah, Yoda, you might be right. I might be going to hell and I'm going to let that thought be. Thank you. And then I'm going to allow my guilt in this moment. And in this case, advance to the present moment, meaning I am here at church, maybe praying or whatever. And then all of a sudden, Yoda says, you're not worthy to be here. And Lex is going to say, well, thank you, Yoda. and you're going to go to hell. Well, maybe, we'll see. Back to the present moment, worshiping, because this is what matters to me. And when things get really, really hard, we want to access that observing part of us, to remember that how will we treat a loved one that is struggling like we are? And, we will ask, Lex, how would you treat somebody? What would you say to them? This is the self-compassion piece. And so we want to access that observing self to remember to be kind to ourselves, for Lex to remember to be kind with herself as she experiences these hard things with OCD, and basically be actively engaged in what matters the most to her every day. So for me, when we talk about exposures, it is being able to engage in life every day and not be afraid of doing what matters to us or avoiding things. I think that's about that.
Yeah. And you know what?
I
I
don't
just
know what
I
else
love
you-
the conversation that we're probably about to have, and just I love these slides because there is so much truth to needing to have this ACT-informed ERP, because we don't want to be just throwing random exposures that could be relevant to the person but may not be. We really want to dig into, like, if OCD wasn't here right now, what would you want your religious experience to look like? Not everyone has the same religious practices. There's so many differences between how people praise their higher being. And some people may say, yeah, I go to church every day. Others may say, I really think it's important to volunteer my time in X, Y, and Z place. So really coming from that space of, like, I value practicing my religion in this way, so I'm going to work toward doing that. Because I think it makes the exposures, even though they're hard, so much more worth it for the patient when they engage in it like that. Just wanted to throw
Yeah,
that.
I want to add one more thing as I'm thinking about the ego dystonic, ego syntonic piece. I have a lot of clients who have scrupulosity OCD, as well as sexual OCD, or they have maybe a history of pornography, and in their faith they should not be doing pornography. So the problem is there is no delete button in our brains. So once they have an image is there, and once a long time ago I had a client who would say, I need to cover up that image. That was the compulsion. I need to cover up that image. And if I don't cover up the image, I believe God will see that I'm not trying. So there is that ego syntonic piece where it's like, I need to show God that I am doing this. And that's where the conflict happens, right? With the religion piece, where like, I have to cover it up. I have to cover it up. And so I just want to share that what we did, of course, we did value-based exposures. And it was really difficult. He kept covering them up. And then as he finally started practicing, acknowledging the thought, acknowledging the image, and also being able to allow the shame and the guilt and uncertainty, eventually he was able to not cover the image and recognize that it was the OCD doing that. So when we finished the treatment, I said, okay, what is, at the end of the day, you learn a lot of skills, but what was the thing that made a difference? And it's not going to be surprising for all of you. It was the exposures. The exposures, the value-based exposures, connecting the value to the exposures. And that is what made all the difference, where, just different skills, they're there, but when you put the ACT psychological flexibility skills with the ERP, it made it for the client to click. And it took a little while, right? He kept doing exposures, repetition, right? To be able to click and be able to say, oh, there it is. There is the image. Okay, there you are. Of course, why wouldn't you be here? Normalize it instead of like, oh no, why is it here? So anyway, I just wanted to share that.
Yeah, it's really helpful.
Okay,
Excuse me. I
so
think.
who
Oh,
has this
sorry.
one?
Is this you? I forgot. My bad. Go ahead,
I
Annabella.
can do that one. That's
Yeah.
okay. I think it was me. So I made this little chart to see the difference between religiosity and scrupulosity. As you can see, the person that wants to live their religion without really the OCD, they have a sincere desire to abide by one's faith principles. For example, live the faith principle of reverence, respect, connection, communication, belonging. The client wants to learn to be aware that there are challenges. They might have made mistakes, but they're not repetitively going back to review the mistakes. Rumination, right, is the opposite of religiosity. So they are willing to experience all the emotions with flexibility. They can experience joy, peace, and flexibility despite the mistakes and imperfection. They acknowledge that they are imperfect and they're okay with that. And they don't worry about what God thinks of them because they recognize that they are imperfect. On the other hand, if they have scrupulosity OCD, I've heard the term the other day, somebody was talking about it in terms of religious perfectionism. And it makes sense because they just want to be perfect in their faith and their religion. So that is the difference. And then the ability to follow faith's recommended behaviors with flexibility instead of being stuck in the scrupulosity trap. Emily and Christen, do you have anything to add to that?
I love that term, religious perfectionism. I think that's that just hits the nail right on the head. And I think for some things, it's also important to remember clients are already in a lot of distress and discomfort, and they're not receiving the positive, or most of the time not receiving the benefits of their spiritual practices that they used to receive. And that can cause them to hold on even more tightly in a much more rigid way because they feel like failure, right? This is when that shame and the guilt and the self-degradation can show up all the time, making, I'm not trying hard enough, hold on, like keep going, do it more and more and more. And we're asking them to experience it, to leave the rigidity behind and get back over to that flexible place with their religious pursuits. And that's scary. And helping them outline their values is such a good way just to even see, like, what are the potential benefits of me trying to get from this scrupulous rigidity over to a more flexible place.
Yeah. And sometimes it's even that 80-20 rule that, like, I'm sure you've talked about with all your patients. I think we all probably have, where it's like, there's some things that will be harder to transition than others, but like, let's just think, what is 80% of the faith population that you connect most with? What do they do? Right? And what do you want to be willing to do? Knowing that most of them do these things, like, how can you practice more in line with others in your faith and your religion? And sometimes that's even helpful to kind of put things into perspective as well.
So I just threw this chart together because I think sometimes we can, as treatment providers, we may not conceptually identify the difference and similarities between exposure and response prevention and acceptance and commitment therapy. And that really, in both areas, we're doing psychoeducation. There is some self-monitoring. There's even this present moment awareness in both sides, right? ERP, we're asking clients to do what we term as exposures, whereas I think, I don't know if it was you, Emily, or you, Annabella, earlier, that I think you said, like, I'm choosing to explore, right? And just, I love that term. And encouraging the client to work on decreasing their giving into that desire to control or get rid of the OCD by ritualizing. we're asking them to really deliberately encounter those obsessions and those emotional pieces and those physical sensations that show up differently. What else would you ladies add?
I think that covers it. And I think this is just a reminder that we don't have to, as providers, so rigidly stick to one modality. I think integrating other components from other treatments and recognizing we're doing it on behalf of the patient to meet them where they are is just so essential as well.
Absolutely. That's an excellent point.
Mm-hmm.
So now let's dig into some mental rituals. And I included the little dog on, who's like, hey, it's fine. Because a lot of times clients are completely unaware that they are engaging in mental rituals. These are covert, hidden rituals. You might see sometimes like, a client kind of gloss over and they're there, but not there. And I do think for some time, mental rituals were often not seen, and these individuals were considered to have what we termed as pure O, or they were thought to be a pure obsessional individual suffering from OCD, which was really challenging because part of the diagnostic criteria has always necessitated the presence of both an obsession and a compulsion. And through research and lots of other lovely ways, we've realized that their individuals were ritualizing internally. And so some common hidden mental rituals might be praying, counting, repeating words, body scanning, checking in lots of different ways, reviewing. So for example, one client in particular who was really struggling with fearful, intrusive thoughts of, what if I blasphemed the Holy Spirit, right? Distress level picking up significantly, really struggling, and internally, just inside their head, they would review, well, first they would start praying, confessing and asking for forgiveness, and then reviewing any known church rules, laws, or doctrines to give them reassurance that the way that they had handled that obsession, asking for forgiveness or perceived sin, was the right way to do it. And now they were free from having potentially blasphemed the Holy Spirit and could move forward. But as with many individuals, the simply praying once and reviewing doctrine one time was not enough. And they were getting stuck in these loops, going over and over and over, trying to get to the place where it felt better, like just experiencing that relief, and it was not happening. And they were stuck. So working with clients also in this area to, while you're going through that, the first few meetings and going through psychoeducation and teaching them about mental rituals and being able to differentiate between what the function of maybe a prayer that is covert might be, really examining the functions. So on the next slide, I just kind of highlighted a few things about treatment approaches with mental rituals. Like I said before, really focusing on differentiating between the obsession and the rituals, right? The function. Obsessions drive anxiety and distress up. Uncertainty becomes present, and compulsions and rituals are aimed at decreasing anxiety or distress and getting to a place where we have 100% certainty, because that's what we want. That's what feels good, right? And knowing that the client can't get there. It's also generally, they are going to experience the presence of a sense of urgency with wanting to pray or wanting to feel better. So examining, again, like looking at the function of obsessions versus compulsions, helping them learn how to identify the function of what they're doing, encouraging them to be a mini scientist. And, you know, often I'll have people maybe even draw a picture of like, hey, what does little scientific cartoon you look like, right? Like, how can we envision that person just going in and having an encounter with what's present where, you know, they can get out their clipboard and they're just collecting data. They're not there to say that what's present is good or bad. And they're just looking at it, and then they can try something. I can try not praying in this moment, and I can just see what happens. Is it as scary as I thought? Was it an OCD thing? Was it not, right? And their little scientist is just in there collecting data. And when we're doing exposures, if we want to intentionally trigger, where we're asking a client not to engage in a mental ritual, sometimes mental rituals are so automatic, it's incredibly difficult for individuals to pause and slow down enough to be able to move through an exposure process. So even having the script, like Annabella was talking about earlier with imaginal scripts, reading something out loud so that they are staying focused on the obsession and not moving right into that automated ritual. Another tool is just really helping the client catch themselves and sit in that space with them, sitting with them as they struggle to the urge to ritualize increasing, having them verbalize a lot of those things out loud while they're doing the exposures, because that's why they're there. They're there for your help. Let's help them move through it. One of the last two is, listen, when you have people who are kind of just automatically jumping in to those mental rituals, they can get so frustrated with themselves because they're tired of this process. They know what they're doing, like, right? They've got all the psychoeducation. And this is also really important later with self-compassion, right? Like practicing in those moments, but encouraging them to mess up any automated mental rituals, right? So if they're already in the prayer, no problem. Don't close it out. Let's change it just a smidge. If they normally have to say amen, we're going to pull that out. And now we land right back in another experiment. I think the other thing is, the last one is more, Annabella, like what you were discussing, where we're going to thank our brains, right? We're going to acknowledge what's present and know that it doesn't have to drive our lives in that moment. It can be here and we can live. We can do those two things at the same time. Are there any other things that you ladies would add in here?
I think you covered a lot of the mental rituals. I think also just to know you should be self-compassionate with yourself as a provider. They're tricky to treat, right? And oftentimes, like you said, it's automated and people aren't necessarily realizing that they're doing it. But even having individuals have go-to phrases, whether you call them uncertainty statements or not, of like, you know, I may or may not have said, or you know, I trust myself more than I trust this thought right now. And I'm going to choose to move forward. And, you know, I'm going to choose to not pray to my OCD anymore. I'm going to pray to my actual higher being. And so just like having those tools as well. But I think you covered it really well.
No, I love that one. Yes. So now we're going to talk about self-compassion. And I think I'm just going to re-highlight kind of what Emily and Annabella have already shared. Self-compassion and compassion, period, is going to be important through the treatment process, not just for the sufferer, but also for the clinician. Scrupulosity, there's always that tiny nugget of egocentric information and beliefs that's at the base of what's going on, and part of what can be difficult to tear apart with a client. They can struggle a lot as they learn how to trust the process and trust in themselves, and the fear increases. And then as a treatment provider, right, just being sensitive to how hard we can be on ourselves in difficult treatment moments. So practicing self-kindness. I think my most favorite self-compassion exercise is the self-compassion break. I have loved that for years and years. It's a beautiful exercise, and it can be so brief, but just teaching the very basic skill of acknowledging the pain, like, by just saying something like, ouch, right? This hurts. It's a moment of suffering. And I know I do this. Like when I do it, I think I've listened to just Christen Neff's recording so many times, just automatic now. But she asks, there's a beautiful recording by Christen Neff where she even says, put your hand on your chest and just offer yourself, may I be kind to myself in this difficult moment. And just those phrases, just very simple, they don't have to be complicated, can give clients this, like a refreshing look at themselves during difficult times. They're having a struggle and we're not responding to it by becoming more and more rigid, right? We don't have to dig in further to our faith beliefs, and we're not doing something wrong. We're having a moment of we're just having a moment of suffering. And clients are going to have slips and relapses. Self-compassion is a huge tool to use during those moments, because I think a lot of times I hear, we have a support group and we get people who attend from all over the state of Texas, and it's amazing. And frequently people show up and they're so upset with themselves, right? Because they messed up, they gave in to OCD. And I tell people it's time to throw a party. And in fact, I have like party poppers hidden all over our offices for when people slip and have a relapse, because now we know one of the ways that OCD was getting at you. And next time we know a little more and we can celebrate because it's here and you're not a failure, right? And learning again, like, may I be kind to myself in this moment? Some reasons why we want to incorporate self-compassion into treatment with OCD period is that a lower self-compassion has been associated with higher OCD severity, right? Difficulty regulating emotions, and it's actually been associated with some of the more difficult OCD thoughts. And lower self-compassion, we know, is associated with caregiver burnout. Nobody here has caregiver burnout, right? If no clinician ever has caregiver burnout. So our clients need it and we need it.
Yeah, and going off of that, I really just want to re-emphasize before getting into how do we really have faith leaders incorporate themselves into treatment and how can we best do that too as clinicians, is sometimes we really do feel like the exercises that are asked of us in treatment may pull us away from our faith, like I've said before, but we're trying to create a genuine connection with God. And just as a reminder, OCD only cares about OCD, doesn't care about your faith, your family, any other values. It cares about OCD and having its way. So even having that reminder when you do maybe fall off the wagon, that OCD cares about OCD, it's not about your faith.
So we want to be able to have leaders' participation in the treatment. Why? Well, when you have OCD and you are a very devoted member of your religion, chances are you're going to end up with scrupulosity OCD. The problem is if the person doesn't know that this is OCD, they're going to think that it's a personal flaw or that it's a faith problem. So it makes sense that they're going to go to their faith leader to talk to them about what their thoughts are, what their feelings are, and all these things. And so that is why it's important for the faith leaders to participate and to understand, because if they don't understand scrupulosity OCD, they might provide the wrong information. I have had clients where they go and they confess their sins, and the faith leader will say, oh yeah, that sounds like you're going to need to do this, this, and that. So they're actually, the faith leaders' well-meaning advice makes the OCD worse for the client. So we want to be able to have the client invite the faith leader, and we're going to talk about that in the next slide. But what we want to do is make sure that faith leaders participate, because we don't want to have any misunderstandings. And also the idea that clients, patients will tend to trust the faith leader more than the therapist, because they will be afraid that if they do ERP, the ERP will be against their faith. So we need to have the faith leader be part of the treatment. And the research talks about how people with OCD, when they hear that, okay, they have OCD, they will prefer to just do medication and not psychotherapy. And we know that the best treatment is the combination of medication and psychotherapy. So that's why it's very important to have a faith leader participation. So let's talk about how we're going to do that next. Will anybody would like to do that one, or we can just all talk about this?
Yeah, I think we can all talk about it, because, it can be so different depending on who you're working with and the willingness actually of the faith leader. Hopefully the faith leader is really open to doing this, but of course, we get an ROI first. I think that's probably all similar for all of us. Get an ROI, and really provide psychoeducation to the faith leader and try and get an understanding of their perspective of it. Like, what are they understanding about it? So that you can more thoroughly explore how maybe some of the behaviors are reassurance seeking and driving the problem, and how they could be accommodating them. And I think one of the things I do, and I'll let someone take kind of the rest of the slide, is I think it's so important that we give faith leaders a role, right? That we give them a chance to be a part of this treatment in an important way too, whether that's by being a motivator for the person that's in their congregation, whether it's, them being a part of this and, connecting with a therapist and being a part of the therapeutic process, so that there's an understanding of what reassurance seeking is happening or what else is coming up. And they are, for lack of a better word, experts in their field, right? They can answer questions that maybe I can't or other therapists can't. So even having them to provide guidance in some ways too, can be so helpful.
Yeah, I agree with that. I think that the faith leader, and we can, I believe that needs to be a meeting between the faith leader, the client, and the therapist, so that all of us are on the same page. And mainly the faith leader needs to be aware of that's reassurance seeking piece, the confessing piece, that and then the client needs to be okay with that, so that when, we can talk about how agree that when the client goes to talk to the faith leader can say something like, well, what have you learned in therapy? Tell me what you've learned. It sounds like it's really hard for you. Literally teach the faith leader how to respond to reassurance seeking issues. Mm-hmm. Also, remind the faith leader that his role is to support and to keep reminding the client to use their faith, how to apply their faith in this journey. It's a difficult journey, but they can do it as they trust their God. Christen?
I think I would just add, I as a clinician, if you're struggling with like how to reach out, or you're concerned that the faith leader won't want to participate or won't get it, I would say a majority of my experiences have been incredibly positive with faith leaders. In fact, I've not had a negative one. I've never had a faith leader get on and go, no, this is craziness, and this isn't real. But instead, the faith leaders are so thankful because they felt like there was just something was going on, right? They weren't seeing this individual experience relief in the same way that maybe someone else in the past has with something similar going on. And so they are delighted to be that support, right? And to learn more about how to be the best support person they could be. And the other thing, and I know you both said, like, I would just reiterate, if we weren't dealing with scrupulosity and we were dealing with something where, you know, the client was going to a friend or a family member, we would include them in OCD treatment, right? Like, we would educate that person and we would talk to them about how do you, this person shows up and wants reassurance or whatnot. And the faith leader is no different. They can play such a big role, and unknowingly so, right? That's not their intent. So I just encourage you to absolutely reach out to faith leaders.
Yeah, I would add the other piece that I was thinking about is, you know, when we're working with maybe somebody who has an eating disorder and they have OCD, and if you're not an OCD treatment provider, you need to talk to the dietitian or the other treatment provider. So you are a team. So in this case, with scrupulosity, you are a team, and the faith leader is part of the team.
Yes, exactly. And I think one of the things we all probably want to end on and close on is just this importance of relapse prevention, and really having this bring it on mindset and using all of these skills and acknowledging that you are strong for even approaching therapy, right? And that we need to convey that to our patients as well, that they are so strong and that recovery is not linear. But I want to give you guys a chance to kind of talk about relapse prevention as well.
I would say, like, the first step in relapse prevention is relapsing. We're not going to prevent it. We're going to allow it. But just education, right? Like I mentioned earlier, it's going to happen. We need it to happen. And that's not failure. It's not everything is, your entire treatment process isn't messed up. You as a clinician have not failed. But instead helping clients develop that attitude of like, all right, let's bring it on. Let's do this, right? I'm ready to live my life for my value system and not the value system that OCD kept trying to give me. So I'm ready to move over here. And practicing that flexibility. Just being, just more flexible and open as opposed to rigid. I can't have thoughts like that. I can't do that. I can't feel that way. And, you know, the experiment, or, you know, the just inquisitive observer of like, oh, hey, what is this? What is this that has shown up today? Interesting. What about other people want to add anything?
I will say also, I tell my clients, you're going to have setbacks. Yeah, of course, part of the deal. And we practice. It's like, you know what? Oh, of course. Why wouldn't OCD be here? Why would, you know, maybe they have made a lot of progress and then they're going to get married. And then the stress goes up. And it's like, well, of course, I'm getting married. Of course, OCD, you're part of this. So I'm not surprised you're here. And we know what to do with you. So that element of don't be surprised is very essential, though I tell them you're going to forget. So just remember that when you start feeling rigid, etc., that means OCD is around. And the other part I want to say to clinicians is be patient. Besides self-compassion skills, we need to be patient. The best rewarding piece for me in what I do is when I see clients after 3 years or 4 years of treatment. These are some difficult clients. It finally clicks. And I'm like, yes, it's so rewarding. So be patient, because it's going to be difficult sometimes. Sometimes, you know, when I meet somebody at the first day and they have scrupulosity, and then they leave, I'm like, oh my goodness, this is going to be hard. Okay, I'm ready for this. And then we keep progressing, and then they have a setback and progress, setback, progress, setback. Eventually, it clicks. And again, the ERP is the thing that looks like that's just, but sometimes you have to do ERP for years in order for them to finally click. And so be patient and celebrate the small successes with your client, because that is so important.
Yeah, and be creative, right? Be creative with your patients. Really try and instill like this sense of, like we've been talking about, curiosity, and how can we approach this in a different way than we have if that isn't working. So I think all of us just are trying to give you all the confidence and also all the comfort that it's okay if our patients don't get better immediately. It's okay if it takes some time. And recognizing that you guys have such a tough job. It's such an important job. And you're deserving of also stepping back and recognizing that this is tough and you can get through it, and you having that same bring it on attitude that you want your patients to have. So with that being said, I want to make sure we have our references shown really quickly. And I want to thank you so much for being a part of this. This was such a great experience for me. I hope it was for you as well. Any parting words before we move on? Go answer all your questions.
Yeah, no, thank you so much, ladies. I really appreciated working with y'all, and I'm excited to answer questions.
Me too.
Yeah, thank you. We'll see you soon.